So good afternoon, everyone. In just a minute, you'll be hearing from Jaime Borkowski on the management of common infections in the outpatient setting. Jaime Borkowski is a clinical pharmacy specialist at Northwestern Medicine Delnor Hospital. She completed her Doctor of Pharmacy at Butler University in Indianapolis, Indiana, and a PGY1 pharmacy practice residency at Northwestern Memorial Hospital. She practiced as a clinical pharmacist at Northwestern Memorial Hospital following her residency, and then as the pharmacy clinical coordinator at OSF St. Anthony Medical Center in Rockford, Illinois. Jaime took a position at what is now Northwestern Medicine Delnor Hospital in 2009 and has spent the last 13 years building their antimicrobial stewardship program. She co-chairs the Antimicrobial Stewardship Committee and the Emergency Department Antimicrobial Stewardship Team at Delnor and works closely with practitioners to improve antimicrobial use at Delnor and across the Northwestern medicine system. Jaime is an active member of the American College of Clinical Pharmacists IDPRN network, volunteering on the IDPRN publication committee since 2015, as well as the Society of Infectious Diseases Pharmacists and the Illinois Council of Health System Pharmacists. Thank you, Jaime.
Thank you so much for that introduction, Jaime. All right, let me know if you can't see my screen, okay?
Yep, everything looks good.
All right, I'm gonna go ahead and get started then. All right, so I have no conflicts of interest to disclose, first of all, and here are my objectives. Now, with this presentation, I realize that I am largely preaching to the choir. So my goal today is to hopefully provide you all with some knowledge, some references and tools to be able to bring back to your sites to address some common areas that need particular stewardship attention. Now, I am going to address guidelines somewhat, and I have a lot of information in these slides. However, in the interest of time, I'm going to probably jump through them a little bit and highlight the things that I think are the most important, and then you have the references and the details in there in case you want them for your reference. If you have any questions about things that I didn't cover in detail that you want me to go back to a little bit afterwards, please let me know, and I'm happy to answer any questions. So let's jump right in. I'm going to start talking about acute respiratory tract infections. So with ARTI, acute respiratory tract infection, I'm including uncomplicated bronchitis, pharyngitis, rhinosinusitis in general. So those are the things I'm going to be really focusing on with this. So ARTI is the most common reason for outpatient physician office visits and antibiotic prescriptions in adults. So of the over 100 million office visits per year in which antibiotics are prescribed, 41% are for respiratory conditions. But an estimated 50% of outpatient antibiotic prescriptions are considered inappropriate or unnecessary. And we all know what inappropriate antibiotic use can result in, including adverse effects, increased antimicrobial resistance, as well as superinfections such as Clostridioides difficile, which you guys have been hearing about throughout the course of the day on all of those counts. So let's start out with acute uncomplicated bronchitis. The main thing with this is that more than 90% of otherwise healthy patients with acute cough have a viral cause. So this is really key in just remembering this with bronchitis. It's more than likely viral. The main thing with this in determining if antibiotics are necessary or not for bronchitis is to rule out pneumonia first. And if the patient doesn't have any evidence of pneumonia, it's probably viral and probably doesn't need antibiotics. Now, one study that looked at this was this study by Lohr and colleagues. It was a randomized placebo-controlled multi-center study that compared amoxicillin clavulanate to ibuprofen as well as placebo in healthy adults who had, or otherwise healthy adults who had cough, discolored sputum, and at least one other symptom of respiratory tract infection for less than 1 week. And they saw no significant difference in the primary outcome of duration of frequent cough between each of the groups. But the antibiotic group had significantly more adverse effects associated with it. So this is just one of those studies that kind of point to this, that for these groups of patients who really don't have pneumonia or do not have pneumonia but have this kind of cough, it's probably viral, and antibiotics probably don't have a place in the therapy. So what do we do for these patients? Really, the main thing to do is give them symptomatic treatment. So, and we'll do this, we'll give them a prescription for these things. So they feel like, they had the visit to get some relief, but it is in the form of something else other than antibiotics. Just keeping in mind that symptomatic therapy does not decrease the duration of illness for the patients. And also, of course, as in any over-the-counter prescribing or other, just be sure the patient is a candidate for that therapy. For example, in decongestants, you might not want to give those to patients who have hypertension, for example. All right, so I'm moving on to rhinosinusitis. This one has a little bit more controversy associated with it, so I'm going to talk a little bit more about this one. So rhinosinusitis is mostly caused by viruses. And when you get to the bacterial rhinosinusitis, it's actually considered a secondary bacterial infection when you get to the bacterial side of it, but less than 2% of viral sinusitis is thought to actually result in secondary bacterial infection. However, the patients that we see, it's probably a little bit bigger percentage of these because of the ones that might not be getting better on their own. Now, here's a little bit of background on sinusitis, but I want to draw your attention to the viral time course. And this is important just to kind of help differentiate for sinusitis, as it is one of those that sometimes does need antibiotics. So the viral time course for sinusitis, usually in the first day or two, the patient may have a fever. However, the rest or the sinus symptoms, such as the nasal drainage, will come usually, 4 to 5 days after the initial fever. So it's a little bit of a separate course, kind of a progressive from the fever to the other symptoms. Now, as far as guidelines go for rhinosinusitis, we have two of them actually. One of them is from the Infectious Diseases Society of America, or IDSA. The other one is from the AAO-HNS, so that's the American Academy of Otolaryngology and Head and Neck Surgery. And these two guidelines are a few years apart from each other. The most recent one was in 2015, but they do differ on a few places. So I want to kind of talk about those a little bit more because it seems to cause a little bit of controversy, I think, in treatment. Now, as far as the definition or the diagnosis of a bacterial rhinosinusitis, I have listed here the IDSA diagnosis. So it's a patient who has symptoms greater than 10 days that are persistent and without clinical improvement, severe symptoms, so high fever, and at the same time, purulent nasal discharge or facial pain for 3 or more days at the beginning of the illness. So having the fever with the symptoms at the same time usually is a little bit more indicative of bacterial infection, so that's more likely there. Or double sickening, which is when a patient has a viral syndrome, they're sick for 4 to 5 days, they get better, and then they end up having new symptoms of maybe an onset of fever, headache, increased nasal discharge after they initially improved. Now, the AAO-HNS definition is a little bit less specific, and it is basically surrounded by starting at 10 days. So if the patient has symptoms for 10 or more days, that's when they start kind of considering the possibility of a bacterial infection, and including persistent symptoms or a double sickening. So with the management of sinusitis, one of the things that's kind of is different between the two guidelines is this thought of watchful waiting. And I've been hearing about this throughout the course of the day for other syndromes. And watchful waiting is a strategy that is promoted in a lot of these types of infections. So with watchful waiting, what it involves is when a patient has been established to have sinusitis, instead of giving them antibiotics because you suspect bacterial, just hold out and wait up to 7 days on that, and then see and reassess them before you give them antibiotics to treat it. So I'm going to talk a little bit more about that, but first let's look at some of the data behind why one of them recommends it and one of them doesn't. So in favor of watchful waiting is the AAO-HNS. And so this on the left side here, I kind of highlight a systematic review. And this review looked at 6 randomized controlled trials that had almost 800 patients, and they were comparing antibiotics to placebo for sinusitis. And then they included trials that evaluated patients who had symptoms of sinusitis for 7 or more days. And the antibiotic group actually did show significant benefit for rate of improvement at 3 and 7 days. However, by day 10, there was no difference seen between antibiotics and placebo. And so despite this better rate of improvement at 3 and 7 days, the fact that there was no difference at 10 days indicates that this may be a self-limiting illness and they may be able to actually spare antibiotics. So the AAO-HNS guideline recommends waiting until this 10-day time to evaluate and then seeing if the patient, actually can do okay without the antibiotics first. Now, the guideline also notes that the number needed to treat for antibiotics to benefit a patient with sinusitis is 11 to 15, which is actually a good number needed to treat. It's not that many patients. However, they also note that the number needed to harm with antibiotics was 8. So even though you need fewer, you don't need that many patients to treat to benefit, you're going to harm more patients in that process. And so the fact that it might be a really self-limiting illness and they might get better on their own after a few more days might be worth just kind of holding off those antibiotics if possible. Now, the IDSA does not recommend watchful waiting when you've established a diagnosis of bacterial sinusitis. And this study on the right looked at something similar, so randomized double-blind placebo-controlled trial looking at antibiotics to placebo in children specifically. So what they did differently here was they had more stringent criteria for the diagnosis of bacterial sinusitis. So more consistent with the IDSA diagnosis guideline. So persistent symptoms, acutely worsening symptoms, or severe symptoms as they defined. Now, it was a pretty small study. There was only 56 patients included. However, they did find a significant difference between the groups. So 50% of the antibiotic arm was cured at day 14 compared to 14% of the placebo arm. And this was significant. So the IDSA points out that many studies that were looking at the use of antibiotics for sinusitis prior did not really have rigorous inclusion criteria, so the benefits of the antibiotics may have been underestimated due to inclusion of patients with viral infections being included in those groups. Because I'm an antibiotic steward, I'm kind of in favor of the watchful waiting route in a lot of patients. Now, as far as the guidelines go, the AAO-HNS doesn't say just watchful waiting for everybody. So they really highlight the importance of shared decision making. And this has to be a conversation between the patient and the clinician, and it's a decision. So if the patient is having really tough time, they're having severe symptoms and they're not willing to wait, it's not wrong if you have a high suspicion of bacterial infection to give them some antibiotics. However, if it's kind of not clear if it's bacterial or viral, because they do overlap quite a bit as far as symptoms go, and the patient is in favor of not having antibiotics if they don't have to have them, then it is something that's definitely a strategy to consider. So if you decide to implement watchful waiting, the way that they recommend doing is, so once the patient presents for care and they have a suspected diagnosis of bacterial sinusitis, you would wait up to 7 days after the diagnosis, and in the interim, manage the patient with symptomatic relief, and then consider giving them a wait and see prescription, or WASP, with instructions to go to get this prescription filled if their symptoms get worse, if they have another high fever, etc. Now, the important thing about using this strategy for watchful waiting is that you have to ensure that the patient is reliable and will follow up, will let you know if they decide that they need to fill that prescription, and that they will come in, at that 7-day mark or whatever, to be reevaluated to make sure that they're doing okay. So that's a key there. So I, again, because my primary role is to steward these antibiotics, I definitely am in favor of watchful waiting when the patient is amenable to it, and that it's something that's reasonable for the patients based on their symptoms. Now, when you do decide that you need to treat, this is another place where the guidelines actually differ a bit. So the way I have this set up, the left column here is kind of your first line options for patients with really no risk of resistance. The middle column is a little bit step up based on some risk factors for resistance, and then I have your penicillin allergy options over here. Now, for the no risk for resistance, the AAO-HNS guideline recommends amoxicillin alone, or you can do amoxicillin plus clavulanate, while the IDSA guidelines recommend starting up with amoxicillin clavulanate off the bat for even this no resistance group. I'm going to talk a little bit more about this in a little bit, but in general, the AAO-HNS guideline does note that amoxicillin really doesn't, there's not really any data showing that amoxiclav is superior to amoxicillin. IDSA's rationale for recommending amoxiclav up front is because of a lack of susceptibility of Moraxella to amoxicillin alone, as well as increasing resistance of H. flu to amoxicillin. However, they do note that their recommendation is a weak recommendation. And the data supporting amoxiclav up front is really stronger in children than adults. So basically, amoxicillin probably in your maybe initial presentation, a patient with not a lot of medical history, or if you know your local susceptibility patterns and that you don't have to worry as much about resistance in your area, then amoxicillin really might be a great option. And I'm going to talk more about this, like I said. Now, second line options include doxycycline. And then I have this little box down here with a fluoroquinolone in it, which is an option. However, as we know, there's a lot of reasons not to use fluoroquinolones if possible. They are last line because of all the adverse effects, the multiple black box warnings, including a black box warning from 2016 that specifically recommends against using a fluoroquinolone such as levo or moxifloxacin for acute bacterial sinusitis, just because of the collateral damage you're doing and a lot of other options that'll work as well. Now, if the patient has resistance, risk for resistance, so this is patients who are less than 2 or greater than 65, who attend daycare, who have had recent antibiotics or hospitalization, lots of comorbidities or immunocompromise. These patients, the guideline, IDSA specifically recommends to start out at high dose amoxicillin clavulanate, the 2-gram BID. And this is more consistent with this group of patients for the AAO-HNS guideline as well. So if the patient does have risk factors for this, then we would start out with amoxicillin clavulanate. Again, alternative options include doxycycline or levofloxacin. And then if a patient has a penicillin allergy, you'd probably go right to that doxycycline. Now, in the case of a treatment failure, you could either step up from whichever agent or whichever strategy you started. So if you decided to do watchful waiting and the patient did not have a resolution of symptoms on their own, you would start antibiotics in the form of amoxicillin or amox plus clavulanate. If you started with amox, you'd go up to amox-clav, etc. Now, if you run out of options here, one other option for a treatment failure patient is clindamycin plus a 3rd-generation cephalosporin, such as cefixime or cefpodoxime. Now, as far as the duration of therapy goes, this is a little bit different between the groups too, the guidelines, sorry. So there's for the patients that are the low risk patients, the duration recommended is 5 to 7 days. And now, as far as evaluation for symptom improvement, IDSA recommends evaluating at 3 to 5 days for symptom improvement and escalating therapy if they're not improved. However, AAO-HNS recommends evaluating at 7 days for improvement because they cite data that actually shows that even when you give antibiotic therapy and you're treating a bacterial infection, it does take around 7 days or more for the patient's symptoms to start resolving anyway. So they do recommend evaluating at 7 days and not earlier for escalation of therapy. Now, if the patient's in this middle group, 7 to 10 days is the recommended duration. And so you may need to go a little bit longer in those patients. All right, so back to the question of amoxicillin with or without clavulanate. Now, this study, I really liked this study. It's for a few reasons. So it's a retrospective cohort study of adults with bacterial sinusitis that was identified by ICD-9 or 10 codes in VA system emergency departments from 2012 to 2019. So the things I like about this is that, first of all, it looked at patients up to 2019, so it's a little bit more current as far as susceptibility patterns. It was also a national study, so it doesn't take one geographical area. It's kind of a good summary of all geographic areas. So again, not as susceptible to susceptibility patterns that are specific to one area. It was also a large study. So they looked at almost 19,000 patients that received amoxicillin and over 70,000 patients that received amoxicillin clavulanate. And they saw no differences in sinusitis-related return visits to any point of care between the groups. So it was almost the same between the two groups. And they also saw no differences in infectious complications or hospitalization for these patients. Now, one limitation of this study was that they identified patients by ICD-9 or 10 codes, so they were unable to really specifically look at patients that had the criteria per IDSA guidelines for a bacterial sinusitis. So in order to try to control for this, they did a subgroup analysis of patients with high fever, and they looked at, they used high fever as kind of a surrogate for severe presentation. But again, with that sensitivity analysis, they still saw no difference between the groups for revisit rates. Some other limitations of the study was that it was primarily an adult, older male population. So it is unclear, how this would be in a more general population. but also the retrospective design does allow for, difficulty in controlling for some confounders, although they did do propensity matching scores, but there may have been some, reasons why only 19,000 patients got amoxicillin versus the more amoxiclav group. So it might be, there may be some hidden things here. However, with the large size of the study, I feel good about this study is using it to support the argument to maybe consider amoxicillin initially in more patients than I think are done right now. I'm not going to go into detail on this slide just in the interest of time, but I do want to point out for chronic sinusitis and recurrent sinusitis, there's really no data to support use of antibiotics in these situations. And in the case of recurrent sinusitis, a specialist evaluation is recommended at that point. All right, so acute pharyngitis, a little bit less controversial than sinusitis. But interestingly, so up to 70% of patients with sore throats in the United States receive antibiotics from their primary care physician, even though usually about 20 to 30% are likely to have group A strep. And if you're looking at the adult population, it's about 5 to 15%. So a very small percentage of patients that present with a sore throat actually have group A strep pharyngitis, which is the most common bacterial version that we see. And patients who don't have group A strep pharyngitis most likely will not need antibiotic treatment. Now, in general, for diagnosis, viral pharyngitis usually has other viral symptoms associated with it. So if the patient has a runny nose, if they have a hoarseness or a cough, then it might very well be more likely viral than bacterial. So just keep that in mind. However, it is really difficult to distinguish between viral and bacterial without just testing. And luckily, we do have a very quick and easy test to do, as most of you are probably aware. So this rapid antigen detection test, is recommended. So basically, if it's positive, it's got a high sensitivity, and so they recommend treating for group A strep pharyngitis. However, if it's negative in an adult, they recommend no antibiotics and do not do a backup throat culture. Now, they do recommend a backup throat culture in children and adolescents, just because it's a higher, pretest probability that the patient's going to have group A strep. All right, so treatment-wise, first line, it's strep. It's so penicillin or amoxicillin works well for patients. In a non-severe penicillin allergy, where the patient has tolerated cephalosporins in the past, for example, you could get away with cephalexin or cefadroxil. And then severe penicillin allergy, clindamycin or azithromycin. Now, this is there's a lot of different options here. One thing that I was wondering about, especially with this use of azithromycin for this, if it really, is something that is effective. So there was a Cochrane review that I found from 2021, so it's really recent, that was looking to assess the comparative efficacy of these antibiotics. And it included 19 trials with almost 6,000 patients. However, despite the number that was there, they were not able to draw any conclusions regarding any comparative efficacy or better outcomes between any pairs of these antibiotics that were looked at. So that included looking at cephalosporins versus penicillin, macrolides versus penicillin, and azithromycin versus amoxicillin. And half of those trials did include pediatric patients primarily. Now, some agents that are not recommended to treat group A strep include tetracyclines, sulfamethoxazole or trimethoprim or Bactrim, or ciprofloxacin. But respiratory fluoroquinolones are an option. They're just not really recommended due to overly broad spectrum and lots of adverse effects, like I discussed. And then the duration recommended is 10 days, except for azithromycin is kind of the 5-day regimen that we all know and love. Okay, so I can't talk about acute respiratory tract infections without talking about COVID-19. Now, don't worry, I'm not going to go into detail here. We all know these stats inside and out. We know these symptoms inside and out. The one thing I really want to point out is that the bacterial and co-infection rate. So just a reminder that the bacterial co-infection rate for COVID-19 is estimated to be 0 to 6%, especially in these outpatients who are not in the hospital and haven't been there for a week or so. It's not likely that they have bacterial co-infection unless they're presenting for something unrelated and are incidentally found to have COVID-19. So here's just a screenshot that I pulled out of the NIH guidelines for management of our non-hospitalized and non-requiring oxygen patients. So basically, all patients should be offered symptomatic management, as with most of our other viral syndromes. And then as far as treatment goes, so for patients who are at high risk of progressing, and I kind of pulled out some of the key ones down here at the bottom. However, there's an extensive list, and I did have a link in the slide here to the actual NIH guidelines, which do have this extensive list of patients who are at high risk of progressing to severe COVID-19. They do recommend using one of these treatment options. So ritonavir boosted nirmatrelvir or Paxlovid, that's a PO option that's readily available now. And it makes it easier for patients to be able to access it if they qualify for it. Although we do have a lot of drug interactions associated with the ritonavir in there. The other first-line option is remdesivir, and that's an IV treatment. That's 3-day course for this group of patients. So it's a little bit more difficult for patients to get if they don't have access or can't get to the infusion center 3 days in a row. Now, the Paxlovid is listed first here because it's oral, but it had an 88% reduction in hospitalization or mortality in COVID-19 patients. So it's a highly effective agent if patients can take it. There's a couple other options down here, which I'm not going to go into detail on, but I do want to point out that the panel recommends against use of dexamethasone or other steroids for patients for the purpose of COVID-19 in this group of patients. In the absence of another indication. So if they have another reason to get them, great, but for the purposes of treatment of the COVID-19, it's not recommended. And also noting that there are no antibiotics anywhere in this guideline. Now, really quick about about Paxlovid. We do know that there are significant drug interactions, like I noted. It's a strong CYP3A4 and P-glycoprotein inhibitor with that ritonavir in there. So there are some common interactions that we see, including anticoagulants, so apixaban, rivaroxaban, as well as immunosuppressants, such as tacrolimus. So when you have these severe interactions, you want to avoid the agent. But there are a lot of agents where there are interactions, but they're manageable interactions. So statins are an example, amlodipine. So they have this, if you haven't seen this yet, the Liverpool Drug Interactions Checker is a very helpful tool. And so check it out if you haven't yet. It can tell you what the interaction, what drugs interact, as well as how to manage those that are ones that are not contraindicated. So take a look, it's very useful. Okay, so let's talk a little bit more about the fun stuff. This is kind of like some of the literature behind how to go about addressing these patients with these acute respiratory tract infections. And so this first study I found really applies to all of stewardship and all of treatment probably. But basically they looked at urgent care centers, and they took the physicians and divided them into quartiles for how likely or how often they prescribed antibiotics for acute respiratory tract infections. And then they compared their patients to see from this index visit what happened after that. So they found that patients who were seen by the highest quartile prescribing clinicians received more antibiotics in the year following that initial index visit for acute respiratory tract infection compared to the lowest quartile prescribing physicians. And you might think, okay, that makes sense. But the interesting things about this finding were that it was also seen with the patient's spouses. So it kind of extrapolated into the household, as well as this difference was actually driven by an increase in the number of visits for acute respiratory tract infection. And so really what this kind of shows is, and their conclusion was that physicians' behavior is driving the patient's behavior. So if we see these patients and we're at the end of our day and we're tired and we don't want to explain to them one more time why we don't give them antibiotics, we just give them a prescription, we're increasing their chances of presenting every single time they have this syndrome for the next year. And they're going to be getting, looking for antibiotics every time they present. So biting the bullet that first time and saying, no, we do not give antibiotics for this is so important because it will help shape how that patient addresses that issue within their family and for themselves on an ongoing basis. And then this study, this study I actually was introduced to probably 4 or 5 years ago at this conference, but I just love it. It was actually from a colleague at Northwestern, Dr. Jeff Linder and his group, and they looked at behavioral interventions on decreasing antibiotic prescribing in ARTI. So they looked at 3 different interventions. So suggested alternatives, accountable justification, where the physician had to specify why they were ordering antibiotics for this non-antibiotic indication, and also peer comparison, where they receive data on how they did compared to their peers, and kind of like, you are a top performer or you are not a top performer, which is always a little zing. So they looked at almost 15,000 patients for their baseline period and then compared it to about 17,000 patients in their intervention period. And they found significant differences for decreased prescribing compared to baseline for the accountable justification group, as well as the peer comparison group. And then they did a follow-up study about 12 months after they removed the interventions and found that the peer comparison group was the only one that still had significantly lower antibiotic prescribing rates. So this is something that I find very intriguing, and so I've really been trying to start incorporating this into my practice. So here's a little bit of a quick example. So initially, this is not what we were doing, but we were trying to really address this problem of respiratory tract infection and antibiotics in our emergency departments, as well as the urgent cares in our area. So we started this work back in like 2014. And so at the time, we had a strong physician champion in the ED as well as at the urgent cares. We created guideline summaries. So one pagers that kind of hit all the key points and what they needed to remember. We performed education to the staff, and we also had those guideline summaries available on our intranet for their review in case they wanted it for reference. And then once it was available, which wasn't right up front, but once we could, in our healthcare system, in our electronic medical record, we created smart sets for the emergency docs to use when they were discharging a patient from the ED that guided them to select symptomatic treatments instead of antibiotics for certain indications. And you can see that over the course of about a year and a half, we did have a nice decrease. I don't have any stats for you, I'm sorry, but we did see definite trends in a decrease in our antibiotic prescribing for sinusitis and then bronchitis. Now, this was all manual data collection back then, and since then we have been able to create a report that pulls out of Epic for us. So this is divided up. It's kind of hard to see, I apologize, but this is divided by syndrome. So here's sinusitis in the left column, URI, pharyngitis, acute bronchitis. And this is actually screenshots of some information that we actually shared with our physicians at one of their ED department meetings. And so I kind of highlighted where they were, how they were doing on these things, as well as that bottom box was we did give them specific information on their prescribing, as well as who were the top performers. So we kind of had this box that was the top performers, and then we had information, and our medical director of the ED opted to share all the information with everybody so everyone could see how everybody was doing. And so they could see, that they did have colleagues that were seeing the same population as they did, and barely ever prescribed antibiotics for bronchitis, for example, whereas they were somehow doing it for 60% of the patients. So it really helps self-reflection on the physician's part. And I do not have any post information on this yet, so more to come, hopefully. And also, I just added this slide this morning because one of our early speakers brought this up. I think it was Melinda Newhouser from CDC, and she pointed out that this is available, and I thought it would be great to include here because this is an MMWR that does talk about ways like publicly reported data that you can actually use and get a hold of to help incorporate this peer comparison type of feedback to patients. So thank you to Melinda for throwing that little nugget in there, because I think that this really might be a good place to start if you're on the outpatient side, because data is always a challenge, getting a hold of actual data. Clinical decision support is another area that will help with this, and my colleague Justin Williams just talked about this a little bit ago and had a lot of really great references in his project as well, or his presentation, I'm sorry. But this group actually looked at something similar to one of the interventions from Dr. Linder's group, where what they did was they basically, at the time of a prescription for a respiratory tract infection, it would direct the physician to documentation within the medical record that was required. So they had to document why they were ordering this antibiotic for that patient. And they were actually targeting fluoroquinolones and macrolides in particular. And they saw, they nearly extinguished unwarranted use of target antibiotics for acute respiratory tract infections with this intervention. So accountability really does help make the physician think twice. Some other frontline interventions include distinguishing viral from bacterial infections, educating patients on the lack of utility of antibiotics, and how long to expect symptoms of a viral infection to last. So they know, just don't go back and ask for more antibiotics or antibiotics again when it's probably still just the course of the virus carrying out. offer the patient symptomatic treatments. And then again, for sinusitis, consider watchful waiting with a backup prescription maybe for patients to help avoid that initial antibiotic if possible and see if they can get better by themselves. All right, so I'm going to pivot here to urinary tract infections. And there's also been a ton of talk today about urinary tract infections. I know that it's one of the biggest problems that we're all facing. So I'm glad I'm talking about it. Again, I'm going to be going quick just because of time. However, so UTI is the most common bacterial infection, 8 million office visits, 1 million emergency department visits each year. And asymptomatic bacteriuria, or ASB, remains one of the most common reasons for unnecessary antimicrobial use. So about 45% of ASB was treated when not indicated. And this was true in this review that looked at inpatients as well as the outpatient subgroup. It was about 44% for outpatients that were treated for ASB when not indicated. Here are definitions of UTIs just for completeness sake, but I'm not going to go through these in detail. My favorite chart. So this chart, I think, really speaks so clearly as to why we don't treat patients for positive urine cultures when we don't have symptoms. So the first thing to really remember is that urine is not a sterile site. So we shouldn't expect to not see anything in there when we check a urine culture. Maybe in a healthy premenopausal woman, it may be about 5% of the time those patients have bacteria in their urine at any given point. So yeah, maybe not so common in those patients. However, when you start looking at diabetic women, which is a pretty big percent of our population, almost 30% of those patients may at any given point in time have bacteria in their urine. And then women and men who are 70 or older living in a long-term care facility, upwards of 40 to 50% of those patients may have bacteria at any given time. So you can see why checking a UA or a urine culture in these patients is going to be misleading unless you have a really high pretest probability for an infection. And this study here at the bottom, I just wanted to highlight really quick. It was actually it was in younger women that had recurrent symptomatic infection. And they were wondering, if we treat the patients that have ASB, are we going to decrease this recurrent infection? And they actually found that treatment of ASB resulted in higher rates of recurrence of symptomatic infection, as well as modified bacteria that they grew. So the patients that didn't receive antibiotics for ASB had your normal kind of E. coli, Klebsiella, Proteus when they had a symptomatic infection. However, the patients that got antibiotics for ASB, when they did have a symptomatic infection, they were seeing E. coli and Klebsiella, but they also saw Serratia and Citrobacter and Pseudomonas. So there are definitely detrimental effects to treating antibiotics or treating ASB with antibiotics, but not necessarily any benefits in that group of patients, at least. Now, there are a couple reasons why we would screen and treat for ASB. Patients undergoing urologic procedures that cross the mucosal barrier, and then also pregnant women. And these two groups have been shown to have detrimental effects of ASB if it's not treated. So that is recommended that it's treated. But this is the patient that we mostly see. This is daily. And Justin confirmed it. He said the same thing. We see these patients every day. And so we have these little old ladies that come in because they fell. And then they're like, oh, they fell, they must have a UTI. But then they get the history, and the patient says, well, they increased my diuretic. And so the patient stops drinking water because they don't want to have to go to the bathroom all the time. And then they get dizzy because they're dehydrated. So they fall. And then they present for care because of the fall. And then they check their urine, even though we know that, some patients up to 50% may have bacteria there regardless. So they end up getting antibiotics, they get better because they got fluids as well. And then their urine culture comes up positive. And then the next time this happens, the family says, oh, well, every time my mom has a fall like this, she has a UTI, and they give her antibiotics and she gets better. And then they insist on antibiotics, which is kind of going back to that initial study I talked about where even for acute respiratory tract infections, the physician behavior perpetuates the patient behavior, or the patient family behavior, as we know. So just keeping that in mind. So with elderly patients with basically prospective randomized clinical trials show no benefits of screening or treating for ASB, although treatment had significantly increased adverse effects, including an 8.5-fold increase in risk of C. diff. As well as reinfection with resistant organisms. So for these patients, the guidelines specifically say Okay, so for patients with functional or cognitive impairment or who experience a fall, who have bacteriuria and delirium, but they have no local UTI symptoms or systemic signs of an infection, to just observe the patient. They say careful observation. So we're not just discounting this, but we're going to observe the patient carefully with no antibiotics and assess for other potential causes of whatever the initial presenting problem was. So if the patient's not clinically deteriorating where they really need antibiotics, hold off for a day, give them fluids and see how they do. And see if you can get away with covering it without any antibiotics. So when you do have a patient with symptoms, we do have to treat them. And I'm going to go through these quickly. I know everybody's very familiar. These guidelines are very old. There's nothing new out there. Maybe some reviews, but yeah, this hasn't changed for a long time. Unfortunately, we're waiting for new ones. But so in your uncomplicated UTI, so young, non-pregnant female with normal GU anatomy, we want to make sure that we're picking the narrow spectrum agent with low potential for collateral damage. That's going to cover the likely organisms. Nitrofurantoin is great. It covers most of the common organisms. It's not great in patients that have poor renal function. So if the clearance is less than 30 to 40 mils a minute, look for an alternative, but it is a really great option otherwise. So that's really first line. It also has very low collateral damage due to lack of systemic absorption for the most part. Cephalexin is another great option. And for us, empirically, our susceptibilities are better for first generation cephalosporins than for even Bactrim. So we prefer to do this empirically for the first gens. And then so trimethoprim sulfamethoxazole, which I apologize, but I'm going to just say Bactrim for ease of saying it because I'm going to be saying it a few times here. But that is also a great option in your patients who are initially presenting, don't have a lot of history of infection, and they're relatively uncomplicated. You may be able to get away with Bactrim initially as well. Although as they get further down in their complicated history, they may not maintain susceptibilities to it anymore. Now, the duration of therapy depends on the antibiotic class. There have been a few classes that do show effectiveness at 3 days of treatment, including cephalosporins do have some data for that, Bactrim, as well as fluoroquinolones. Now, fluoroquinolones, this is another group. Again, this is another indication that was included in that 2016 black box warning saying, do not use fluoroquinolones for acute uncomplicated cystitis because there's other options that are better due to, just the risks associated with it. There might be a role for them, if there's allergies, resistance, Pseudomonas. Okay, but don't reach for those right away initially unless you have to. Now I have amoxicillin on here, not a great empiric option. However, in a patient that does have enterococcus, it is an option. And then fosfomycin is a one-time dose. That is another potential option, especially if you have an ESBL for some reason, which probably isn't likely in this group of patients. Now I do have cefpodoxime listed on the bottom there. You'll notice that is an option. However, there was a review done and looked at first generation versus third generation cephalosporins for failure rates, and they found no difference empirically for failure rates between those two groups. So unless you have something driving you towards the third generation cephalosporin, the first generation is recommended, and there's a lot less collateral damage with that one as well. All right. So complicated UTIs are pretty much any other patient that has a cystitis that isn't included in that first group of uncomplicated with just your kind of young, otherwise healthy patients. Now, I will say that even though like our elderly patients may have some reasons for being considered complicated, so maybe they have renal failure or urinary retention or something along those lines, if they have a history of a susceptible organism to a first generation cephalosporin, that's what we're going to be using to treat them. If they have a cystitis, we will still empirically try to cover the most likely susceptibility pattern from their most current culture. So looking at those recent cultures is really helpful if you have access to them to help guide your treatment for your patient. If you don't have access to that or the patient doesn't really have a history, the local antibiotic resistance patterns are helpful. And I was asking about this morning because I know that they're talking about regional antibiograms for Illinois, and those do seem to be they're coming. So hopefully we'll have better access to local kind of regional data to know kind of what our susceptibility patterns are in places that don't have access to a lab that can give you that information. So another big group in this complicated UTI is the males, because usually males are associated with prostate or structural issues. So for that, when you're treating a male, because of the risk of prostate involvement, it's important to use an agent that will penetrate the prostate. So the two recommended agents are Bactrim or ciprofloxacin. Bactrim, because of resistance issues, might not be the best empiric option unless, again, you have a recent organism that does show susceptibility, and it's likely to remain susceptible because you didn't use it, or then it is an option. But in general, I like to make sure it's susceptible to Bactrim before I use that empirically. Now, if you have a patient who's a male who does not have any prostate involvement, so they don't suspect prostate, there's no pyelonephritis, you may be able to get away with nitrofurantoin or fosfomycin if you need to. However, again, you have to really make sure it's just a pure cystitis and nothing else going on. Treatment is for 7 to 14 days. And really not a huge benefit from 7 to 14 days based on this little study down here at the bottom that I also heard about this morning. I'm learning all kinds of things today. And then again, fosfomycin might be used for ESBLs. For the more complicated cases where you might need a longer course, there's no standard dose for anything other than once, but you can do every 2 or every 3 days. And I do have this middle reference at the bottom does have a little bit more information on fosfomycin. So if you're interested in looking at different dosing strategies for it, that's your reference to look into more. There is even some data that may suggest if you needed to use it in a patient with prostatitis, then you might be able to do 3 grams once a day. And it didn't seem to have any safety issues associated with it, but there needs to be more data on these studies. So this is just all kind of theoretical if you need to, because you have an ESBL that you're having trouble treating. And then pyelonephritis. So basically, empiric therapy, again, should make sure that you get adequate tissue penetration into the kidneys. So Bactrim and Cipro, again, are good options for this because of their great tissue penetration. Now, Bactrim, again, if you have an uncomplicated female who comes in with really no history of antibiotic use, you may be able to get away with Bactrim. However, ciprofloxacin is going to be more reliable as far as coverage. It also has an approved shorter duration of 7 days for a pyelonephritis. Usual treatment duration otherwise is 10 to 14 days. Now, there are patients that can't get Bactrim and can't get Cipro. So what do we do in those patients? So cephalosporins might be an option. I don't recommend it empirically unless you have to. The guidelines do not recommend it. And there was actually a review done that looked at the role of first generation cephalosporins for pyelo, and it did not, they were not good initial treatment options. If we know we have susceptibilities and we do a little bit of IV in the hospital, for example, we might step down to PO cephalosporins. In the outpatient world, though, it's a little bit trickier. The guidelines do say that if you do need to use Bactrim or a cephalosporin, you might consider giving a one-time IV dose of ceftriaxone and then give them the PO, Bactrim or cephalosporin until you find out what the susceptibilities are for that agent. And there are some data actually showing success with cefaclor for treatment of pyelonephritis, and it had similar outcomes to Bactrim and ciprofloxacin, although the study is older. Now, speaking of cephalosporins for UTIs and pyelonephritis, they're an older class of antibiotics, so there's not a lot of current clinical data on the use in these infections. But one of the questions is, were these older studies that looked at them really using adequate doses, especially for systemic infections like pyelonephritis? Now, this is a really awesome table that Justin Williams shared with us in our group, and from Mogul and colleagues. And they look at different time above the MIC, which is our pharmacodynamic target for cephalosporins, for various MICs of E. coli. And I just want to point out here, so I highlighted a few different agents. So cephalexin at 500 milligrams Q6 will be adequate tissue penetration, or for a bacteremia at least, at about an MIC of 2. But if you raise the dose of cephalexin to 1,000 milligrams Q6, you can get it to adequate tissue concentrations at even higher MIC of E. coli. Cefaclor and cefpodoxime are also other options that do reach adequate concentrations, but they're at more susceptible MICs. So a more resistant organism would not be a great option for these. So if you don't, now we know that a lot of times we don't get MIC results for oral options. Hopefully in the outpatient world, this is a little bit different. But in the case where you don't have access to that, using the wild type MIC for the highest frequency is the one I recommend using. So for E. coli, for example, it's 4 for cephalexin. So we would want to use the 1000 milligram Q6 in this case. So just keeping in mind that if you do have to go to a cephalosporin for a pyelonephritis, making sure that you're optimizing that dose and really pushing it as high as you can to make sure that you're getting adequate concentrations to really treat the infection. Okay, I'm not going to talk a lot about UTI prophylaxis. I have information here. The one thing I want to point out is that prophylaxis does have some success in the studies. However, it also results in almost 100% of resistance of antibiotics, or I guess 100% of the time you will see increased resistance. So over 90%. This is specifically in catheterized patients. They do note that methenamine may be an exception for that resistance because we're not using that in practice. And then recurrent UTIs is also a problem. Just a couple of things I want to point out. For older patients, a lot of times it's related to other things than actual just infections. So they have a lot of options, and I have the review down here that does go through the different non-antibiotic options to consider for postmenopausal women. So estrogen supplementation, D-mannose, and then if you do have to do something that's more of an antimicrobial, methenamine may be your option. Try those non-antibiotic options first before you go to an antibiotic to try to prevent infections in these patients. Okay, so stewardship opportunities for UTIs. I'm running out of time, but a couple of things. So I have these 2 articles here. This top one by Claes and colleagues goes through a lot of different options. And again, Justin's talk did review a lot of this as well, but there's a couple of things. So for education and local guidance documents, we know that even though physicians are even aware of what ASB is, they're not really sure or not comfortable saying, okay, this is one of those patients and I'm not going to treat them. So even if they can identify it, they still don't know how to manage it. So giving them education and guidance on when and when not to treat these patients is really helpful because they're just not comfortable with it. And then diagnostic stewardship. So that's what Justin's whole talk was about. Requiring the clinical indication of urine culture at the time of ordering, including education on when it was appropriate, did reduce inappropriate urine culture ordering. So this is kind of the same thing. If you're requiring accountability and they have to say why they're doing this thing that's really not recommended, it's going to make them think twice and maybe hopefully decrease the number of unnecessary cultures that we're seeing, and then requiring, making the physicians feel like they have to treat this positive urine culture that didn't really have a purpose. And then the second article, they actually used selective reporting of susceptibility results for the preferred or first-line antibiotics. And in a vignette study, they saw an improved rate of adherence per the guidelines from 22 to 67% for these 3 different case examples that they were looking at. So using the lab reporting capabilities to really drive the treatment that they select to what you want them to do is helpful. And so it's kind of like with what we always say, make it easy for them to do the right thing. Make that the easiest choice. Some other frontline interventions for UTIs include choosing the most narrow spectrum option that makes sense based on the patient's type of infection and likely resistance patterns, and avoiding fluoroquinolones when there are other reasonable options. Optimizing your cephalosporin dose to ensure adequate treatment when you need to, if you have to use it for upper tract infections. Narrowing the antibiotic if possible once the cultures are back, although this may be a little bit trickier in the outpatient setting. Using the shortest effective duration. And then when you have a patient with a recurrent UTI, try non-antibiotic strategies first before jumping to those antibiotic strategies. All right, so I have my key points listed here, and I'm not going to read through them in the interest of time. I also have some useful resources from the outpatient perspective as far as guidelines go, and then also just pointers and education for physicians, lots of different stuff available on the CDC website and the Choosing Wisely campaign. So please check those out at your leisure. And then I want to acknowledge my colleagues who helped me a lot on this presentation, just reviewing and giving me feedback. So Therese, Lena, Mike, and Charlene, thank you so much. And with that, I will open it up to questions.
Jaime, if you'd like to review your key points at the end, we don't actually have any questions and we have about a minute or so left. So it's totally up to you.
Sure. Okay. Let me go back up. Let's go to those. I'm going to make it small, leave it small if that's okay.
Yeah, that's totally fine.
All right. So for bronchitis, basically, there's no indication for antibiotics unless you've, as long as you've ruled out pneumonia and offer the patient symptomatic treatments. For rhinosinusitis, you can consider antibiotics if the patient has symptoms for 10 or more days, severe symptoms or double sickening, but consider watchful waiting if there's high confidence that the patient will return for reevaluation. And you may want to try amoxicillin first. It may be the preferred initial agent for patients who are uncomplicated. Pharyngitis, a negative rapid antigen detection test for group A strep indicates the very unlikelihood of infection in an adult. So you don't really need antibiotics in those patients, and you don't retest or don't check a culture. COVID-19, antibiotics are very unlikely needed in this group of patients. There's really no role for them in their treatment. And then nirmatrelvir ritonavir is an option to prevent progression to more severe disease, but you got to watch out for the adverse or the drug interactions. In general, behavioral theory and clinical decision support may be the next steps to help aid in effective stewardship interventions for common problem areas. And then for UTI, there's very few indications for patients who have a positive urine culture without localizing symptoms of an infection. So ASB, there's very few indications for antibiotics in these patients. Treatment of ASB may result in more frequent symptomatic UTIs. So when you are treating a symptomatic UTI, choose the narrowest spectrum antibiotic for empiric symptomatic treatment, or UTI, sorry, based on the local susceptibility patterns as well as the patient history. Treat the shortest effective duration based on the antibiotic that you choose, and as well as the treatment response. And then diagnostic stewardship can help keep clinicians accountable and also guide them to preferred antibiotics. All right, does anyone have any questions?
It looks like there are no questions at this time, but Mark Gregg did leave 2 comments. The first was, that's why having the CDC or homegrown, you don't need an antibiotic for a viral illness posters in the lobbies and waiting rooms in primary care EDs and ICCs are so important.
Yep.
And his second comment was, outstanding job as always, Jamie.
Thank you, Mark.
I do just want to say thank you so much, Jamie. That was an incredibly thorough and informative presentation. I'm confident that the audience will be able to take this back to their own institutions. We have just about 3 minutes left. So if any other questions come in, we can definitely have Jamie answer those. We do also have a cool feature in these breakout sessions for moderation. So if you would like to come on and join Jamie for a more personal conversation instead of just typing in a question into the chat, you're welcome to do that as well.
Definitely. All right. Thank you so much, Jamie.
Mm-hmm.
think you're on mute.
Okay, can you hear me now? I was just saying our next session is opening up. It will start in just about 5 minutes, but you'll have the option of clicking into those sessions now. So go ahead and click the session that you're most interested in, and we can leave this session now. Thank you again, Jamie.
Thank you. Bye-bye.